There's a fair amount of variability in drug exposure from patient to patient, and we want to move towards really dosing medication in a way that is specific for a patient. The minimally effective doses that have been identified in package labels are good for a certain population of patients, but not for everyone, and we need to be more thoughtful. So a strategy that's been employed at the University of Florida was to develop assays to detect common beta-lactams, cefepime, piperacillin, meropenem, ceftriaxone. We have 10 total beta-lactams that we will do assays on different samples in order to identify how much drug is in any one particular patient. And so as patients come in and have an active infection, we then early on are able to then grab samples, assay it, and then make dose adjustments based off of that assessment. In contrast, most other facilities are just changing the infusion strategy in order to achieve that goal of maximizing drug exposure. We've taken it one step further in saying we want to know exactly how much drug is floating through the vein at that point in time. We get 2 concentrations, we make an assessment, and then our goal is that we get enough drug on board to make sure that we achieve cure, hopefully get enough drug on board to minimize resistance selection, as well as make sure that we don't overshoot our target and increase the risk for toxicity. So our outcomes today have really been centered on, are we able to achieve our desired goals? This has been the first one, and what we see is that there is, consistent with what's published in the literature, there's a fair amount of variability in that most of our dosing strategies that we've integrated into practice using intermittent infusion strategies, by the way, oftentimes don't achieve our desired targets. And our desired target is a time above the MIC for clinical cure of 100%, which is a more aggressive target. In order to suppress resistance, we actually looked at a Cmin to MIC ratio of 4 in order to really try to really push the envelope to make sure that we not only kill the organism, but that we also don't allow or select out for more resistant pathogens. With that information, what we're starting to see, especially if you take different populations of patients, we don't have a ton of outcome data. Some of the outcome data that we have in this cystic fibrosis population, which is a little bit different and a little more complex in regards to their infections, but we're seeing much longer windows of time that they're out of the hospital with exacerbations. We believe part of that, the only thing we've changed is that we've maximized drug exposure to try to decrease the bacterial count enough to where they have a longer time that they're at home and don't need to get retuned again. And so that's some of our earlier data, really focusing on pharmacokinetics and really what is the real issue. The other variable is what are we starting to see from an outcome, and more is to come on that.
I think it's important to remember that with the beta-lactams, they're optimized by time above the MIC, meaning you need a sufficient concentration for a given amount of the dosing interval from that standpoint. One thing that's really nice about the beta-lactams is they're generally very well tolerated agents, and that gives you some opportunities to do some things. So the first thing that you should be doing in these patients is giving the maximum tolerable dose. So you should be at the upper end of these package insert doses. I think that should be standard of care for patients when they're getting beta-lactams. They are safe because of all that variability that we just talked about. You can get past that the best you can by giving them the most drug that you can. In addition to that, because they're time-dependent antibiotics, you can do things with the infusion in order to keep concentrations above that MIC for longer periods of time. Ideally, you would give them as continuous infusion. You would always be above the MIC, but that can create some logistical hurdles. And so one thing we try to do and at my institution we do as standard practice to try to optimize those exposures is we split the difference. We give the beta-lactams as extended infusions. Pretty much 3 hours is our standard that we'll do in that situation. And again, that allows us to be able to keep the concentration above that MIC for longer, hopefully optimize patient outcomes, including clinical cure, hopefully decrease resistance development, all of the things that we previously discussed from that standpoint. I think it's worth mentioning that there are folks who are kind of hesitant to go to extended infusions, because basically what's happening in that, if you go to extended infusions, is you're 4 times a day tying up a line for 3 hours. That's 12 hours, that's half the day, and there are concerns with, that line needs to be there for other reasons. They might have to give other medications. The patient might not want to be tied up to a pole the whole day from that standpoint. But what I'll tell you is for that everything that we've talked about so far, the risk of not doing that is simply too high. The benefit of extended infusions outweighs any of those issues, and I found in my experience that as long as you detail and you talk to those end users and you explain to them what you're trying to accomplish and why, you can be very successful in getting that done.